So this one was a 41-year-old male who presented with a rash. The rash started 2 weeks ago. It is intensely pruritic and it's most prominent on the elbows and knees. Um, he denies any recent travel, hiking, or known changes in lotion, laundry, detergent, etc. He denies any fevers, chills, or myalgias.
Oh, so that's it, Joseph, the chief complaints and the HPI.
HPI,
Okay,
yes.
very interesting. Yeah, so I see we're in the territory of dermatology today, and so a rash. We have not heard what kind of rash. Rash is a very general term, but then we are told this is a 41 years old male, right? If
Yes,
yeah,
yes,
so
41.
41 years old male presented with a rash for how long?
2 weeks.
So a 2 weeks history of a rash. Can you just take me again through the short HPA so I can follow?
Yeah, so he reports 2 weeks history of intensely pruritic rash that is most prominent on elbows and knees. He denies any recent travel, hiking, or known changes in lotion, laundry, detergents, etc. He denies any fevers, chills, or myalgias.
Okay, so I'll just start with some broad comments. So when I hear about a rash, when there's any skin presentation, there's a number of ways that I approach it, but one of them is just to think about general categories. Like if you see a rash in a person, it can be an infection, and so we have a number of infections that can present with rash, and so we are told that this patient doesn't have any fever, any chills, any myalgias, which yes. So there are some, for example, when you talk about arboviral infections, we have a specific syndrome called arthritis and rash. So this patient doesn't seem to have a fever, although absence of fever does not completely rule out an infection, because it could be a localized infection. For example, an infection that is involving just the skin. It's not a systemic infection. So, but then so that is one broad category, that is infection. And when we talk about infection, so again, there is a number of categories. It can be bacterial, and yes, we can have bacterial infections which present with a rash. Can be viral. We have a lot of viral exanthems, so measles, rubella, and many others. It can also be fungal. So, and it can also be parasitic. So there are parasitic infections that can present with a rash. That is one big category. And then the other category is autoimmune slash connective tissue diseases. We know that things like SLE can present with a rash. We have a number of vasculitis syndromes which can present with skin rash, and many other autoimmune diseases that you can think about. So dermatomyositis, that is inflammatory myopathies, can present with a rash. So that is the second category. And another one is drug reactions. So drug reactions can present with a rash. Drug reaction with eosinophilia and systemic symptoms, and many other drug reactions can present with a rash. And then another category is malignancies. So you can think of a number of malignancies which can present with skin lesions, maybe not to say a rash exactly, but because again it's a non-specific term, it's a broad term, and therefore, again, you can think of a number of malignancies that can present with a rash. Kaposi sarcoma, it's skin lesions which are more of nodules rather than a rash, but you have a number of other malignancies that you can think about. Cutaneous T-cell lymphoma and many others. Although now the specific lesions will tell what exactly we are dealing with. So those are the broad categories. And another is just to think, okay, we are seeing a rash, could be coming from the outside. Of course, another broad category that I haven't mentioned yet is allergic reactions. So atopic dermatitis and any other sorts of reactions apart from drugs, because that was a very specific category. So atopic dermatitis and so atopies and allergies in general. So that is another broad category. So uh, big bucket. Now we are told that this rash is pruritic. Now maybe I think this is something that I'll need to go and check back on. That when you hear that a skin rash is pruritic, what does it tell you? So because there are some skin rashes which are non-pruritic, some others are very pruritic. So of course, when you hear of pruritus, one of the things is that there's involvement. We know that allergies, particularly, are pruritic. For example, if you talk of atopic dermatitis, it is pruritic. And yeah, so I think one of the things that I'll have to work on now is to go and make sure that I hone this better to determine when I hear a skin rash which is pruritic, which ones do I rule in, which ones do I rule out. Although I know that especially for atopies and allergies in general, those ones can be very pruritic. But then even infections. So for example, when you talk of fungal infections, like it's not a thing that comes to mind with this patient. But if you talk of uh, uh, infections like ringworm, tinea, they can be very pruritic, and therefore I think pruritus itself does not really help me narrow down that much. So absence of systemic symptoms, as I said, maybe speaks against a systemic infection, but does not rule out infection completely. Then the location. So the location, we are told that it's more prominent on the elbows and on the knees. Of course, we want to know exactly which parts of the is it the extensor surfaces or flexor surfaces, because atopic dermatitis, for example, involves commonly the flexor surfaces, but there are other things that we need to consider. The age of this patient, I'm not saying it cannot happen, but I think it's probably very uncommon for atopic dermatitis to start at 41 years of age, and maybe it's something that did not start earlier than that, maybe during childhood and adolescence, during childhood more commonly. So the location says some things and makes some differentials less likely than others, the age of the patient, and then the type of rash, which of course we'll figure out later. So let's proceed, Joseph.
Thank you very much. So many teaching points. Um, Age of onset of AD, location, etc. Yeah, so let's see. The next is the past medical history. So this is a known patient with celiac disease and currently being managed with nutritional changes involving gluten avoidance with intermittent success. He does not take any chronic medication or over-the-counter supplements. Family and social history. He denies tobacco, alcohol, or illicit drug use. Appropriate cancer prevention screening up to date. No other members of his household have similar symptoms. Works as an accountant with no changes in working environment. Yeah,
Yeah, so
that's the next up.
can you come back on the past medical history again?
He's known with celiac disease, current managed with nutritional changes involving gluten avoidance with intermittent success. He does not take any chronic meds or over-the-counter supplements.
Okay. Yeah, so those are additional pieces of information. So in the past medical history, what we see significant is celiac disease. But so family social, no smoking, no drinking. I believe that's what I heard, and uh, non-contributory family history. So with regards to the celiac disease, a number of things that come to mind. So yeah, celiac disease is associated with one condition, and if I remember correctly, that is erythema multiforme. So uh, yeah, so I got some help here, and yeah, this was helpful. I almost said if I remember correctly, and then I got some help here. So I think it is confusing between the two. Is it erythema multiforme? Is it dermatitis epitiformis? I believe it's the latter, dermatitis epitiformis. Celiac disease is associated with that. So another thing is, so patients with celiac disease will definitely have some sort of malabsorption. So if they have many episodes of diarrhea, they will have some sort of malabsorption. And with malabsorption, they can have electrolyte abnormalities, which of course we do not really expect to present with rashes. But another thing is micronutrient deficiencies. So someone who has a deficiency of vitamins like A, for example, um, A particularly, of course, E is also has some roles, especially when it comes to epithelial maintenance. But we know A is very important in that. But then, so the rash of vitamin A deficiency is more of a scaly rash. It's like someone is desquamating. So there's a lot of scaling, although we have not come to physical examination. But that's another thing that from a distance I'll think about, is are there some micronutrient deficiencies which are causing this rash? So yeah, additional pieces of information is the skin lesions that are associated with the particular condition, celiac disease. And yeah, I believe that is dermatitis epitiformis more than erythema multiforme. And another consideration is the micronutrient deficiencies I was talking about. Although I'm still very open to the other big buckets that I talked about. So let's proceed, Joseph. Joseph, if you are speaking, you're muted.
Yeah, okay. I'm trying to upload the picture here, but gaining some difficulties. So let me okay, let me see. This one is, yeah, so the picture is coming. Yeah. There. Can you see it,
Yes.
David?
Yeah. I was muted. Yes, I can see the picture.
So let me maybe,
Yeah, can you put it on slideshow? I think it will become
yeah,
yeah, it will become bigger. So what I'm seeing here is, and again, because you see it from up close. So what I'm seeing basically is there is a erythema, especially the bases. The bases look erythematous. I see some grouped lesions. Now the exact, I believe, if so if you are seeing this patient, you can tell, because I'm asking myself, is this a vesicular rash? Are these vesicles? So if they are fluid filled, they are vesicles. If there is no fluid in them, because they look raised, these are not macules. So it's they either papules or vesicles. So if they are fluid filled, so to me, I'm not exactly sure, but the way they look is like they are kind of fluid filled. So grouped. So if they are fluid filled, it's a vesicular rash. So there are vesicles in groups on an erythematous base. So the peripheral areas, I'm not sure if those are scratch marks, but well, the primary lesions are those ones. So it's a vesicular rash. I think if there is they are vesicles, if they have fluid in them, because it's very difficult to tell from this side. And then I see an erythematous base. I do not see any obvious scratch marks, but
they are
then
vesicular.
yes, they are vesicular. So it's a vesicular rash on an erythematous base. a grouped vesicular rash on an erythematous base. I think that will be the shortest explanation that I have. So this is on which part of the body?
Yeah, so a rash like this is present in this patient on both elbows and knees.
Okay.
Yeah.
Yeah. So that's my description of the lesions. Anything else that you have on physical examination?
Yeah, so the vital signs are within normal limit, systemic exam is normal, and now the diagnosis.
Okay. So it's time for the diagnosis. Yeah. So
Yeah,
a vesicular rash like this one. So when you are dealing with vesicles, now I think I'll represent the problem once, and then I'll discuss what are my thoughts. So this is a 41 years old male, known patient with celiac disease, on treatment with dietary modifications. So not very successful in treatment, if I remember correctly, intermittent success. He presents with a 2 weeks history of a rash that is more prominent, a very pruritic rash, which is more prominent on the elbows and knees. Now I do not remember, Joseph, if you told me whether they on the extensor or flexor surfaces, but then
extensive.
on the extensor surfaces, yeah. Uh, I've already talked about the past medical history. So family social history, non-contributory. This patient has no history of travel. That's very important. No history of new personal care products, soaps, uh, nothing new which could point in the direction maybe of something like allergy, contact dermatitis, or anything of that sort. And then there are no systemic symptoms. Didn't have fever, chills. Now on examination, we see grouped vesicles on an erythematous base. So I believe the locations are the same. The extensor surfaces of the elbows as well as the knees. Uh, Vital signs normal, systemic examination unremarkable. So at this point, I'll discuss the differentials that come to mind of the vesicular rash. Yeah, so as a reflex, when you think of a vesicular rash, definitely herpes zoster will come to mind. Herpes zoster will come to mind, or if it's you are talking of something primary, then varicella. Yeah, a rash of varicella is also can also be vesicular, but then a rash of varicella is more it's widespread and not just involving the elbows and knees. But then when you talk of herpes zoster, again, what we see commonly is that it involves dermatomes rather than existing in multiple places at once. So we would see that if you are talking of zoster, we would see that in a single dermatome, and that is it. And then another differential. So I'm not considering zoster in this patient. If it was an immunocompromised patient, we see disseminated zoster, and therefore it can be systemic, coming also with fevers, chills. Those are the symptoms of systemic toxicity, which we do not see in this patient. Another another differential is herpes simplex. Herpes simplex type 1, type 2, yes, they also present with a vesicular rash, but the locations that we are told are not the common locations where we see herpes simplex. So basically, we see that, for example, oral herpes simplex on the sides of the mouth or in the genitals for herpes simplex type 2. Well, they can happen anywhere. I mean, we cannot just separate on saying type 1, type 2, this and that, because of changes in sexual habits. But these are not so based on these are not the typical locations where we see herpes simplex. Now, uh, just based on that, we cannot rule them out, although this patient lacks risk factors of which could lead to herpes simplex, for example, being seen in places other than the places where we commonly see them. So if this was an athlete or someone who is involved in contact sports, so whether wrestling, uh, playing rugby or American football and sports of that kind, you can see herpes simplex in other places because of contact. But then this person works as an accountant. I do not remember hearing that he's involved in contact sports. So herpes simplex, I think less likely. Zoster I've already discussed, less likely. Um yeah, so what remains, the locations of dermatitis epitiformis, I think, is in keeping with this patient's presentation. So there could be some other differentials that I haven't. Maybe I think by rushing, there's it's probable that there are some differentials that I'm skipping, which can present with the vesicular rash. But so what I'm thinking of, absence of systemic symptoms speaks against disseminated infections, just like I talked about. They do not seem to be much of allergies or atopies because of the reasons that I explained earlier. So, based on the location of these lesions, the pruritus, I cannot remember correctly whether dermatitis epitiformis presents with the pruritus, but so one thing that I remember is that, as I said earlier, that celiac disease is associated with a rash, and I believe that is dermatitis epitiformis. So based on the location, based on the underlying condition, which is celiac disease, I think the most likely diagnosis here for me, and I'm presenting it as a provisional diagnosis, the most likely diagnosis, but keeping my mind open because I think there are some gaps. So for one, I have not settled down to think about all the possible differentials of a vesicular rash. I've just mentioned quickly some, and then by association, because of the celiac disease and the location of the lesions, I'm thinking this is dermatitis epitiformis, although I'm open to other differentials and learn from my mistakes. So back to you, Joseph.
Yeah, thank you very much. That's a very good job. And again, very good job from Dr. Einstein. This is an Einstein of medicine, I believe. Thank you. When we just said celiac, Einstein posted dermatitis epitiformis. So this guy knows his or her medicine. Yeah, so I think that's the correct diagnosis, and this diagnosis that was reached by the people who have posted this case in the um, HumanDx. Some teaching points here. So the patient was diagnosed with dermatitis epitiformis and was referred to dermatology for skin biopsy and histopathological confirmation. Gluten-free diet counseling was reinforced, and short course of steroid was prescribed. Some differential diagnosis here for pruritic rash can include atopic dermatitis, as David correctly said, bullous pemphigoid, scabies, contact dermatitis, or dermatitis herpetiformis, like in this case. But given the acuteness of presentation, appearance, and associated history of celiac, dermatitis herpetiformis was the most likely diagnosis. So the pathophysiology of this disease, it is caused by an IgA autoantibody against epidermal transglutaminase, which are of, is called TG3. This is found in the skin. So the antibodies, they deposit in the dermal papilla and form a complex with the TG3 produced by keratinocytes, which causes a local inflammatory response and hence the inflammation and the rash. Diagnosis is made by clinical appearance and the presence of associated condition, which is celiac, although direct immunofluorescence is the gold standard to confirm diagnosis. But also serology or histopathology can be used. One clinical period to learn in this case is that ELISA testing for IgA antibodies to that TG3 has a reported sensitivity of 52 to 100 and a specificity of 90 to 100%. So for histopathology, a skin biopsy of the entire vesicle is preferred and typically demonstrates accumulation of neutrophils at the tip of the dermopapilla. So treatment is lifelong gluten-free diet, which is the first line. But if there is flare-ups, patient can be given dapsone, steroids, or sulfonamides. And with lifelong gluten-free diet, full resolution of GI symptoms of celiac disease and dermatitis herpetiformis can occur within a mean of 2 years. Yeah, so those were the teaching points, and that was the short case of today. Yeah, so what happened with Dr. Einstein, I think, is should happen in real life. If you have a case, you have to share with your colleagues. You don't know, like maybe like David had forgotten some sort. Remember that there is a rash associated with celiac, and then someone else remembered it more correction posted. That's why you also present cases here. And for me, when I presented my cases here, I want to see how other people are thinking. Maybe I was wrong, and some time comes out, we both think alike, which is very nice. Yeah, thank you, David.
Thank you very much, Joseph. On reflections for me, and so one of the differentials that you mentioned there is you mentioned scabies, which did not come out in my list of differentials, I believe. And so for pemphigoid, pemphigoid I did not consider it that much because uh, could be a differential, but for me, because the lesions were vesicles rather than bullous lesions. So bullae are bigger than, they also fluid filled, but then bigger than vesicles. But I think one important differential that I missed and should have mentioned was scabies. Although now when you come to see this rash, yeah, so basically, even the rash of scabies, because the mites are basically burrowing, and therefore you see that rash, but it's more of a papular rash with the erythema that we see, like in this patient. I'm not sure about the vesicles. I believe could be happening, but I think scabies was a very important differential for me to consider in this patient, at least before I saw the images, and therefore that was a big miss on my side. But once again, thank you very much, Einstein, for the help, because that came exactly on point when I needed it the most. So I remember that celiac disease is associated with the rash, and sometimes I do confuse between these two rashes, and then help came immediately. So thank you very much for that, and thank you, Joseph, for presenting the case. Dermatology, you need to see a description of the lesions, and the endless list of differentials that comes. So it's not very often that we discuss demo cases here. So that was very helpful. Thank you very much. Yeah, so we still have plenty of time. I'm not sure if there is anyone with anything to share. If you've seen a patient in whom you suspected dermatitis herpetiformis or any of the differentials that we talked about, you can share, and that could stick with someone. And next time they see a patient, they make that diagnosis quickly. So anyone with any experiences or anything to share before we close, please welcome. So if there is anyone, you can just unmute yourself and speak, because the crowd is huge today. I cannot see everyone, so you can just unmute and speak. See, I do not see any hands. So Joseph, as you can see, the crowd was huge today. So I think the maximum I saw here was 75 people. So we've reached 50s, a few times 60s, but today I saw the maximum number was about 75 people. So there are new groups of people that are coming up. Well, so we've had first year residents. I believe this is not the first time here. So we welcome them very much. And then some MD4s again today. I shared the link with them because one of them asked me that we hear there is this thing that is going on. Are we allowed to join? And can we have the link? So I shared the link, and she did a good job to share with colleagues. So these are open sessions. You do not need permission to join, and that's why even the link we keep it open. And just hope that everyone who joins is just for learning purposes, and do not posting or sharing their screens and disturbing the sessions. But otherwise, it's an open session, so everyone is welcome. So for those who are joining for the first time, and for those who have been here for a while, whenever we share the link, feel free to spread it as widely as you can. And you can also share the link of the WhatsApp group that we use for sharing the links of the sessions and the YouTube recordings. And these are not meant to be sessions for just one or two institutions. They are basically for everyone on any part of the world who needs to join. Therefore, if you have colleagues in other institutions in the country or outside the country, feel free to share the links. And you can also share our YouTube links where the videos are. And just in case we forget to share the links of the recording, you can subscribe and put your notifications on, so you can get the sessions when we post them on YouTube. So please share as widely as you can. And once again, we keep on calling. So those people who have cases that we can learn anything from, not necessary to be difficult cases. So we present cases, even malaria here. So if you have a case that you think we can learn something from, you can just reach out to me or Joseph, and then the stage will be yours to present the case. And people who wish to discuss, you also welcome. We are in desperate need for discussants. So because we need to learn from new people every day, so we need discussants, we need presenters. So please do that. uh, Anything from anyone before we close? Joseph, do you have anything?
No, I thank everyone for being here. Seems people love medicine. Yeah, very nice.
Yeah. So it's I mean, coming to spend the hour or so on a Sunday night, of course it speaks a lot about your determination. So congratulations, and we are happy to have everyone around. So in case there is nothing from anyone, on Sunday, I believe I will make efforts to prepare a case that was attended locally here to Joseph. It will be a very interesting case, so no one should plan to miss, because it will be a very interesting case with a lot of teaching points, and we'll learn a lot from Joseph. So make sure you do not miss that session. And as always, we'll remind you, and when we remind you, remind others. So see you next weekend, and have a good night.
Good nights.